My name is Emmy Betts, and I serve as the Deputy Director for the Injury and Violence Prevention Center here at the University of Colorado Anschutz Medical Campus. Today's presentation is part of our monthly Research to Practice webinar series, where we present topics in injury and violence prevention. Before I introduce today's speakers, a few logistics. The session will be recorded and we will send the video link to everyone who registered. You can also find past webinars online and at our website, and we'll put that link in the chat box. Please put any questions for our speakers in the Q&A box. We'll be having a moderated Q&A at the end of the session. And then please mark your calendars for our other webinars. For 2021, they'll be each month on the second Tuesday of the month at noon. And next month, we'll be talking about violence prevention in schools. And then after today, if you're excited to keep talking about opioid use disorder and approaches to prevention and treatment, you can join us tomorrow, Wednesday, for an informal discussion group at 4 o'clock Mountain. So if you're interested, please contact me or Lucia. And so now it is my great pleasure to introduce today's speakers, both of whom I am fortunate to actually get to work with in the emergency department. First up is Dr. Jason Hoppe, who's a clinician researcher, medical toxicologist, and associate professor of emergency medicine here at the University of Colorado School of Medicine. He's also a consultant in medical toxicology at Denver Health, Children's Hospital Colorado, and the Rocky Mountain Poison and Drug Center. His clinical work, research, and public health efforts are aimed at addressing the complicated decision-making process regarding the prescribing of opioid analgesics and effectively initiating treatment for patients with an opioid use disorder. He's a national expert in prescription opioid safety, prescription drug monitoring programs, or PDMPs, and ED buprenorphine use. Dr. Hoppe is a founding member of the Colorado Consortium for Prescription Drug Abuse Prevention, and he's assisted with multiple public health efforts, education programs, and successful legislative changes here in Colorado regarding PDMP access, opioid prescribing, and medications for opioid use disorder. And he is joined by the fantastic social worker from our department who's leading a really amazing efforts. Angela Kushnoid, I can't talk today, I'm so sorry. Angela Kushnood is a licensed clinical social worker, and she's the manager of the emergency department care management team at the UC Health University of Colorado Hospital. She has a diverse clinical background with experience working in human trafficking prevention and rehabilitation, psychiatric rehabilitation, community mental health, managed care, and in hospital settings. Angela helped to create our UCH ED buprenorphine induction program in 2018, building a network of 17 different community partners with over 50 clinic locations for follow-up treatment throughout Colorado. She's been highly involved with assisting other hospitals in setting up their social work roles within ED induction programs through her partnership with the Colorado Hospital Association. So thank you so much for joining us. I'm going to turn it over because I can't talk today, but really excited to hear what you have to say. Thanks so much.
Great, thanks. Again, my name's Jason Hoppe. Thanks for joining, and I appreciate the opportunity to share about our program that Angela and I have put together. I'm going to talk for a little bit, and then I'll hand it over to Angela, and we'll kind of go back and forth from there. So just a little background. So first, conflict of interest. This project was supported by the Colorado Office of Behavioral Health, and we thank them for their support. And it's really focused on programmatic implementation. And while we used a lot of research and best practices to build our program, we didn't do actually any research. So just to be clear. So why are you here? Why do we care? ED visits for opioid overdoses have gone up every year for the past 10 years. And there's a significant risk of dying in that first year after the ED visit. We'll talk a little bit more of that coming up, but only about 5% of EDs offer treatment currently across the country as of a couple of years ago. And about 20% of patients who need treatment actually are accessing treatment. So there's a tremendous gap in coverage for patients who have an opioid use disorder and are looking to get into treatment. Also, the emergency department, for those of you who don't work in the ED, it's really a place where we don't check insurance. We have a very low bar for entry into all of our programs and to be seen. And so it's an opportunity to address a lot of disparities in treatment. This is our map of coverage. All of the white spots mean there is no MAT or MOUD, buprenorphine providers. I'm going to use MOUD, which is medications for opioid use disorders today. Old term was MAT, medication assisted therapy. And we've changed that because most patients do well just with the medicine, and the medicine's not assisting anything. And so you can see huge swaths of the country have no coverage, including large parts of Colorado as well. So there's a huge treatment gap, but why is this a new idea to emergency medicine? For those of you who don't practice emergency medicine, it's a relatively new specialty. We've got about 40 years under our belt here, 50. And really, for a vast majority of that time, have spent it as treat them and treat them. So meaning make them feel better and get them out of the emergency department. This longitudinal approach and linking patients with care and initiating treatment is relatively new, and probably based on recent legislation is going to become a larger part of our job going forward. So we have a new behavior for the ED. And so we built this project based upon the theory of planned behavior, which is one way to introduce provider change. And so there are three main tenets in this approach of how we change behavioral intentions for providers. And those are attitudes. So doing this is the right thing for my patient. This is a lot of education, a lot of socialization. I'm going to spend about the next 5 minutes sort of giving an overview for those of you who haven't seen it about why this is the right thing to do. Perceived norms. So most of my peers are doing this. So this can be social norming. This can be pressure from peers. This can be pressure from coworkers. Really, how do we bring up the level of care so that we're all expecting the same things? And then most of this project, to be honest, was really focused on number 3, which is the perceived control. So these are busy places to work. All providers are busy. We spend a lot of time doing non-clinical things. How do we introduce something new and make it easier for people to do the right thing without creating work for them? And so we'll spend a lot of time talking about that. But first up, the education. So because this is potentially a public health group, what are our chances of dying in 1 year after an ST elevation heart attack? So that's the big one with the stent. What is your chances of dying 1 year after an ischemic stroke? So for those first two, we spend a lot of resources and dollars. We have 24/7 coverage for the hospital. We have specialists on call. We have an ambulance that drives around with a CAT scanner in it to speed up the timeline versus an ED visit for a non-fatal overdose. So that could be you received naloxone, Narcan, the reversal agent, from a friend, family, ambulance, or the ED. So it turns out the chances are pretty close to the same for survival. So we talk about resource allocation. Now, you could argue a lot of these numbers are the result of the resource allocation. And I would argue that if we put the same amount of resource to opioid overdoses, that number would be a lot lower. So these are patients that we touch in the emergency department. We have an opportunity to change. And we know actually when we start them on treatment that number is a lot lower. And so there's a huge opportunity there. What about other common things that we see on a regular day-to-day basis? So how many people die every year? Tetanus. So if you have any break in your skin, paper cut, otherwise, and have not received a tetanus shot in the last 10 years, you're very likely to get one before you leave the emergency department. Anaphylaxis, a severe allergic reaction. We see lots of allergic reactions. We see lots of patients home on powerful medications and epinephrine pens and an opioid overdose. Potentially, we give naloxone, although not as much as we should. So how many people die per year based on what the resources we put into that? It's not really close. So there are many orders of magnitude larger number of opioid overdoses. And remember, that's just the tip of the iceberg. So those are the people that die that we pick up. The actual burden on society of lost days of work, treatment, associated complications from disease is much higher. It's 78 billion per year. Believe it or not, is a sort of middle of the road. There's estimates all over the place, but I sort of tried to pick a middle one that gave us an idea how much we're spending as a society. So where are we? This is the most recent 12-month provisional count. So you can see that for a couple of years there, 2018, 2019, it looked like we were making progress. And like a lot of other deaths of despair, COVID has had a negative impact, and those deaths have continued to rise. Colorado specifically, you can see here, pretty similar graph. Of the 81,000, now this is drug overdoses, about 80% of them are opioid related, just to give you a number. And in Colorado, this is a recent data pull from the SUDORS group, which looks at a smaller cohort of patients that we have more data on, toxicology testing, death reports. And so you can see there for Colorado, about 70% of them, they've identified an opioid. These are not cumulative. You can have a lot of overlap. Significantly, a lot of methamphetamine, amphetamine in Colorado, more than a lot of other states. And you can see the third thing on that list is fentanyl. So fentanyl is a major issue. Hopefully you've heard about it and are aware of it, but this is sort of a look back to when the first opioid wave hit us, going back to 1999. And I bring this up because we saw heroin go up, and we saw, actually, if you look at prescription opioids, which is that aqua blue line, pretty leveled off. So we spent a lot of resources changing provider behavior to get away from opioids as the first choice, and actually looks like we're making some progress here. Definitely prescribing has gone down nationally as well. But again, you see these fentanyl deaths going up significantly. And that really, we talk about resource allocation, spending a lot more money to change prescribing, while important, and decreases exposures to opioids. Really, the most bang for our buck is going to be getting treatment, getting these patients on treatment and protected from that fentanyl. For those of you who haven't seen this, this is a great picture. I don't know why the vials are so big, but if you look at the heroin, that's how much a lethal dose of heroin is. Next to it's fentanyl. And next to that is carfentanil. Carfentanil is in the supply. It's used medicinally, well, I guess medicinally. It's used in the veterinary context for large animal takedowns, so rhinos and elephants. You can see what the potency difference is between those. And you can imagine if you look at that fentanyl vial, that's where most of it's much easier to get a synthetic fentanyl through the mail in small amounts compared to getting heroin from the Middle East and South America. And so that fentanyl is coming from China. It's then getting mixed with inert substances or other medications and sold on the street. And you can imagine there's not a lot of product control there. So it's pretty hard to tell how much fentanyl is in anything until you actually test it. So the people who have an opioid use disorder using it are really rolling the dice. The good news is we have treatment. So medication for opioid use disorder has a lot of societal and personal benefits. And I'm not going to go through those here, but I would point out that the flip side of it is that if we do nothing, even motivated individuals, when you follow them over time, 95% of them fail per year. So there really needs to be an intervention here, and we need to get these benefits to people. And the only way to do it is to actually start the treatment. Importantly, that intervention has also been proven to be useful in the emergency department. This sentinel paper is from Yale in 2015. In that green group, you basically got a phone number for motivated patients. You got a phone number, as to where to go. That's probably the standard of care for a lot of emergency departments. Brief intervention, you got the phone number plus some motivational interviewing, some additional help. And then the red one, you can see there, that's when we start treatment. And so there was some pretty significant benefit there. And this really kicked us off in the emergency departments. I would also point out that their follow-up rate at 30 days is 80%. You're not going to see that repeated anywhere, just to keep that in mind. This is a well-funded, randomized controlled trial, and there's going to be some voltage drop when we turn it on elsewhere. So for those of you, again, who are not in emergency medicine, I keep talking about this great medicine and buprenorphine. I just wanted to take 3 slides to sort of give a very high-level view of why we think it's such a great idea. It is not a new medicine. It's been around since the 70s, although the use for opioid use disorder has climbed significantly in the last decade or so. So why is it beneficial? It treats both cravings and physical dependency. So people feel better, they crave the drug less. The effects are what we call a partial agonist. So as you take more up at a certain point, you get no further effect. So if you look at the graph, if you continue to take morphine, you continue to take fentanyl, at some point you're going to have all your receptors bound and you're going to have the maximum amount of opioid activity and you're probably going to stop breathing. Whereas buprenorphine, once you get them all bound, because it's partial, you do not get any further activity. And so that's what we call the respiratory ceiling. So at some point, if you take too much, you may have signs of opioid overdose, but you won't stop breathing and die. Also has less euphoria, less potential for misuse. And if you think about this nice steady line there, once you have a steady state in your body, it's not the physiology that you get anytime you're injecting, smoking, snorting, where you're all throughout the day, you're going up and down, up and down, up and down, which makes it hard for you to hold down a job, take care of your family, et cetera. So number 1, partial agonist. Number 2, it has a high affinity for receptor. So not to nerd out too much, but this is the inhibitory constant. It's a relative representation of how much a receptor likes a drug. The lower your number, the more likely the receptor is to grab onto that drug. And so buprenorphine, because its affinity is so high, will displace other drugs. So that means two things. One, if you were to look at our graph again, if a person lived at pretty high levels of opioid activity, you could potentially induce withdrawal by dropping them down. So we need to make sure we choose our population appropriately. But two, you're protected. So if you do slip up, remember, opioid use disorder is a chronic disease. Just like diabetes or high blood pressure, people will have times where they're not in compliance. So if you slip up and you use fentanyl or you use heroin, you're not going to die because a percentage of your receptors are bound, and the receptors prefer this. So you're protected from that overdose. Number three, it works fast, which is great for the emergency department, right? We're starting a treatment that we're going to see response within an hour, and we know it lasts a long time, so it's protective. So also thinking about bringing this into primary care practices is something where we can watch somebody get better in front of us and know that they're blocked for a while. So that's the education piece. Trying to bring that into how do we normalize this behavior in our department. A lot of that is sort of, there's a lot of bleed over between the two. So once people know it's the right thing to do and the department expects it as the standard of care, it really raises the expectations for us. We also are fortunate to have a lot of active nurses, and then Angela's team that you're going to hear about in a second, who are really nudging us along. It's a different conversation when the nurse comes to you and says, hey, did you see that this person has signs of injection drug use? Did you see that this person's on a high amount of opioids? They've asked me, they may not have said anything to you. And that nudge can be really useful because they see that the other attendings and other physicians are practicing a certain way, and they can help bring up that practice. Feedback to providers. So you can see at the bottom there, we have a dashboard for opioid prescribing. In the next month, we'll have one for opioid use disorder. So how many people should we be starting on? How many people are getting naloxone? How many patients are we actually initiating? And so that's our next step. That's being built now. We've also done some feedback emails in both directions. So if we missed a case, what can we do next time that better to catch that case? And if you picked up a great case, how do we give positive feedback? Next up, we try to align our incentives. So there is some financial reimbursements that's now available for ED induction. And so that's kind of our next step, is to align those finances, what we think is our best practice. So a majority of the rest of this comes down to that third aim, which is really perceived control. So how do we get providers to feel confident in safely incorporating a new practice without increasing their workload? And so this, when we initially started this project, this is really what we were looking at, is what are the administrative barriers, right? Can we get our policies up to date? Are there technological barriers that we need to overcome? We'll show you our pathway in a second and some order links. What are the workflow barriers, right? How do we offload providers, right person, right job? X waivers, I'll talk about in a little bit for those who don't know what X waivers are. And then barriers for patients. What do we need to do to get the medication to the patient, get that close to the patient, get them follow up, help them apply for insurance? So when we talk about operationalizing a program, this is pretty common for what we do for our opioid interventions. We identify a best practice, and you can see I wrote in blue some of the things that are specific to this program, but we identify a best practice. So we're raising the quality of care, decreasing variability around that practice. We make it the path of least resistance. So how do we, again, offload providers, make it easy for them to do the right thing? How do we find the right person for that job? Oftentimes it's not the physician, and you can imagine asking physicians to do more often is met with some resistance as well. And then the follow-up. So the follow-up from the ED, we've had a navigator program for a number of years. That's great to get patients follow-up, but most of our patients are not within our own system. So how do we get them follow-up outside of our system? And that's a lot of what Angela's going to talk about in a sec. And so where were we before we started? We didn't have a way to identify patients. We had no treatment approach. We didn't have enough X waivers. For those of you who don't know, in order to write a prescription for buprenorphine, you need to have this X waiver from SAMHSA, which is a special addition to your DEA license, requires 8 hours of training for physicians, 24 hours for APPs. So it does require extra work. So we incentivize providers to get enough of them. We've got about 25, 26 providers right now. We didn't have community follow-up. Our social work time was limited. and Angela will speak to that. And then we had a lot of busy providers that already had other stuff going on. We did have some good stuff. We had the nurses were already doing screening, which is great. We did have some social work that was being built up. Our behavioral health team is there, and we have patient navigators, which is a lot of emergency departments don't have. And then a lot of departmental support. So we're accustomed, our department and our providers are accustomed to being innovative and are open to trying new things, which is really helpful. And then lastly, we had some money, which obviously helps as well. I'm going to pass it off to Angela. Thanks.
Thanks, Jason. So first, before I go into the social work role, I want to talk a little bit about how we got to be 24/7. So we received a grant in 2018 from the Office of Behavioral Health to basically develop and implement our ED buprenorphine induction program. We had very limited hours, as Jason just talked about, for social work. We were 8 a.m. to 8 p.m. Monday through Friday, and on the weekends we had coverage by the inpatient social workers, which is really a skeleton crew. So we used some of the funding that we received from our grant to expand social work hours, and with that I was able to get 2 full-time overnight and weekend social workers. That expanded us to 3 overnights and some weekend coverage as well, which was really great. Once the grant ended, it was the easiest case I have ever made to our chief financial officer to fully fund those positions. There's lots of work for social workers to do in an emergency department after hours, which typically tends to be the busiest time. So that's kind of how we got to where we are. So for the social work role, we identify these patients in a few different ways. Number one, we do that expert screening the nurses do, the audit C and the DAS on all patients that are coming back to the main ED. We do have a question about, do you use IV drugs? And if that flags, social work sees anyone that triggers positive. So we catch some patients that way. Sometimes it's a consult, the nurse or provider, the patient has disclosed to them that they use. And then the other one that I think we see more commonly is patients coming in with a chief complaint of withdrawal. They don't feel good, they came to the ER, they heard we might be able to help. The expert screening we do on all patients that screen positive for that, whether it's opioid use disorder, alcohol, other drugs. We're really, one of the most important things social work does is assess motivation for treatment. So we are a very harm reduction mentality program here, and we really have a low bar. If you tell me you're willing to follow up, you're willing to try it, great, we will get you set up. We do a lot of motivational interviewing as well as a part of that. If you want to go back, actually, Jason. There we go. So part of our work with the patient, we do 2 forms with them. Number one is the DSM-5 criteria. So a lot of our community partners want to see that our patients are meeting criteria, which everyone has. We've never had someone that did not meet it. So we've got the DSM-5 checklist on the right. We really like this because patients are, each patient's different. Some patients don't feel good, they don't want to talk, they want to just fill it out on their own. This is a great checklist from It Matters that they can do that. And some patients prefer to have you read it to them. So we use the treatment needs questionnaire and the DSM-5 criteria, which goes through things like tolerance, withdrawal, social activities, things like that. We also have the patient sign a 42 CFR auth for release so that we can get bidirectional feedback from our community partners at the end, which I'll talk about in a little bit. If you want to go to the next slide. So the treatment needs questionnaire, we chose to use this rather than ASAM criteria because it's pretty straightforward. It was developed out of Vermont. So this, like I said, with the DSM-5 is a nice checklist we can give the patient or we can read to them. It goes through social, legal, lots of different factors. Is your housing stable? Lots of social determinants of health. We use this as a guide rather than the truth. A lot of programs will use this to determine where you need to go. But our program, our social work team is a little bit different in the approach we take at university in that we're really looking at each patient as an individual and looking at their psychosocial factors. So if you're homeless and living in Aurora, you're staying at a shelter in Aurora, I'm not going to send you to an opioid treatment program where you have to go for daily dosing. You're not going to be successful. You likely don't have transportation, things like that. Insurance is less important, we found. We were a little bit nervous when we started with the number of patients that have Medicaid or are uninsured in general. We'd heard from a lot of programs, oh, people will tell you they take Medicaid, but when you call with a referral, they're suddenly going to be booked. And that wasn't the case. We've had the easiest time with Medicaid, as well as uninsured patients, because there's so many grants in Colorado that we can easily send to the OTPs for daily dosing. So we're really looking at the social barriers and social factors to figure out where someone's going to be the most successful. If you work and you have a stable job, it might be easiest to send you to a primary care clinic that has an X-waivered provider where you can go once a month if they're comfortable with that. Versus if you do really need that structure, we might send you to an opioid treatment program where you have to show up every day for a while before they can kind of taper you down and see you once a week, then once a month. Social work is involved in setting up. We prefer to have every patient leave with an appointment, obviously overnight. Sometimes if we're sending someone to primary care as their follow-up with like an OBOT model, we might not be able to get that, but we'll make sure to call them the next day. But the majority of our patients do leave with an appointment. Patients have much more likelihood of showing up to an appointment if they leave knowing when that appointment is. We lose a lot of patients just not answering the phone after they leave or not having a reliable phone number. So that creates some challenges there. Social work will let the provider know when their appointment is, and we will try to get them, or we will get them a prescription to last at least through the day that their appointment is. Usually plus 1 day is just a cushion in case something comes up and they have to reschedule their appointment. On average, it's, I would say, 2 to 5 days for follow-up, but usually a week is the standard script we ask for, depending on when that appointment is. And then all of these patients we discharge with naloxone as well. We got a wonderful grant recently, a little less than a year ago, from CDPHE directly, was given to our social work team to be able to discharge patients with naloxone who don't have insurance. So Medicaid covers it, most insurance covers it. It's a pretty reasonable price. We do have social work charity funds that we're able to tap into. So if someone's uninsured, I'm going to send you to an OTP where they have wonderful grants. But I might have to put a medication voucher in to cover your Suboxone or buprenorphine until your appointment, but then that naloxone is usually pretty expensive without insurance. So we have this grant now and can provide that to patients as well, which is great. Community partners. So when we were really building this program just about 3 years ago now, we started with 2 community partners, and to date we have 18 unique partners with over 50 physical clinic locations where patients can follow up. And that's really primarily the Denver metro region. We know some of our other partners are all over Colorado, but we are pretty saturated in the Denver metro region with where people can go for follow-up, which is great because like I was speaking to before, we really try to figure out where the patient's going to be the most successful, where's the most convenient for you, that's going to give you the right care. We ask for bidirectional feedback on our referrals. So we will follow up with some regularity with our partners and ask how things are going. Is there anything missing in our referral packets that you would like to see? Do patients come in with the right understanding? Sometimes patients are in pretty bad withdrawal and they might take too much of their medication before they arrive. We've kind of worked out some of those kinks as we've gone along, but we are always asking for feedback as well as giving feedback. Some of our partners, Stride being one, formerly called MCPN, they actually kind of aligned with us when we were building our program. They started an MAT program, they called it back in the day, they still call it that, around the time that we were building our program because we've always worked very closely together and they wanted to be able to help serve our mutual patients. They will sometimes have folks that they're established with that want an induction, they want to quit using heroin or whatever they might be using, and they can't get them in for a couple of weeks. So they will tell them to come to our ER. They'll give our social work team a heads up. We'll do the induction and then it's great. They've already got their follow-up set up. So really that close relationship with our community partners helps make us successful. When patients don't show up, a couple of things might happen at the beginning of our program. I was personally calling patients to see what happened. Most of them had just overslept. We might reconnect them with the clinic, and most of them are pretty good about getting our patients in pretty quickly. Nowadays, most of our community partners, if the patient no-shows, they will call them and see what's going on, see if they can reschedule. We also have access to Rocky Mountain Crisis Partners. They have a specific opioid use disorder follow-up program. So we offer that to all patients, see if it's something they're interested in. We do a warm handoff in the room with them, and then they get a supportive phone outreach within 24 hours of discharge, addressing any barriers. Did you pick up your medication? Do you have transportation to get to your appointment? Those kinds of things. So one thing we do want to kind of optimize is just aftercare, kind of the transition between the ED and the community setting. It would be great if we had the bandwidth to call all of our patients, make sure they showed up, see if there's any barriers. we're just not quite there yet, but we rely on our community partners for that.
Great, amazing work. So this, I just wanted to show you, I'm not going to go through this in detail, but this is our pathway. Our emergency department uses pathways of care for common conditions. This is our first version, and I bring this up for just two reasons. One is that we've automated the identification of patients, so patients can be identified by themselves, by the provider, or by the nurse in that screening, and any of those can drop a consult to Angela's social work team. You can see in the first draft, Angela really laid out all of the things that were necessary, but as she says, now they're on autopilot. And so in our version 2, you can see that box is quite small. And so the pathway is the same. So people come in, they get identified while the social worker, after an initial interview, does their part. All of the medical work gets done to stabilize these patients. We have very few contraindications. To be honest, I think we've only turned away, Angela can correct me, but I think about 5 patients. Most of those were not related to any of these. Most of those were related to multiple treatment failures or really severe co-occurring psychiatric disease or substance use disorders. But we have a very low bar, and keep those 5 patients in mind when we tell you how many we've started in a minute. And then really, I talked about automating things. So now it doesn't show up here because this is a few months ago, but now you can order all of these things for our patients, all of the orders, labs, medication, the objective screening tool can all be done with one click. So the provider really has to get in here, one click, and should really be out, and all of the care should be started. And the labs, I just wanted to mention, we do screening for hepatitis C and HIV. And if they do screen positive with a new, or they have been not followed up, Angela's team has the opportunity to get them in with infectious disease to get them started on treatment as well, which is great. And then this is the second part. Again, I'm not going to spend a lot of time talking about the actual medication in and outs, but I did want to mention the X waiver. So I brought up the X waiver before. So our workaround is that we have the ability to call other providers from the department. And we encourage this to happen and have operational support to have them come over, briefly see the patient that social work thinks is a good candidate, talk to them. They bring in a dot phrase. So that's a phrase within the EHR that really requires about 3 or 4 letters and will populate. They do the minimum that's required by law to start treatment, and then they go back to their patients. And so they'll write the prescription. By that time, the patient will have follow-up and will know how much they need. And so it's a pretty quick pass through. Some of this obviously takes time. As I said, it takes 15 minutes to an hour for patients to really feel better, but it happens pretty seamlessly.
So wanted to talk a little bit about our population that we've served. We have been tracking the patients that we've done inductions on over the last 3 years, initially for our grant purposes, now just out of curiosity and for research. The majority of our patients have been white males, but it has been a bit of a mix. Most common diagnoses are opioid use disorder, opioid withdrawal, and then cellulitis or an abscess. Just under 90% of our patients either have Medicaid or are uninsured, which, going back to those perceived barriers at the beginning, we're actually really excited about. Private insurance is very low, about 7%, and those patients can be a little bit tricky with where they can go for follow-up when insurance is really dictating that. And then Medicare, we've had about 5%, so pretty low numbers there. On average, ED length of stay is about 79 minutes. So that takes into account some of our more complex patients who do end up in our CDU or our clinical decision unit for observation, as well as patients that maybe have taken Suboxone in the past and been successful. We can see them in intake, get them a bridge script or just a prescription until their appointment, and social work will follow that up. So definitely a variety with each patient, but on average, pretty low length of stay.
Yeah, and I didn't put it in there, but to give context, that's lower than our average length of stay.
And then outcomes. So just shy of 3 years now, we've seen just about 400 patients. 91% of those agreed to induction on bupe. We have refused that we're aware of, that social work was involved with 5 patients. Like Jason said, those weren't really contraindications. One that comes to mind is a patient who believed he'd been red flagged in the entire state of Colorado, where no one would give him opioids. So he wanted Suboxone just to avoid withdrawal for 3 days so he could drive to, I think, Idaho or Iowa he wanted to get to, where he planned to get opioids and continue using. So he wasn't willing to follow up, wasn't motivated. So it's an example of someone we've said no to. Social work's been able to follow up on 92% of our inductions. And with that, we found that 53% followed up for their initial visits. We think that's a little bit lower, just like we've been saying with our lower bar. So a lot of programs might be a little bit picky and have more requirements in who they'll do an induction on. Like I said before, we really just ask if you're willing to follow up and you're motivated. Great, we'll try it. 83% of those patients that we set up have an actual appointment versus 17% walk in. Towards the beginning stages of our program, we were finding that patients that had an actual scheduled appointment, there seemed to be a little bit of accountability there where we had higher show rates at the beginning. I haven't looked at it too much recently, but versus a walk-in where there's no one waiting for you. So I would say things like Kim at BHG is expecting you. If you don't show up, she's going to call you. I'm going to call you. Things like that seem to go a long way at the beginning. So 53% showing up for their initial visit that we scheduled compared to 45% still in treatment at 30 days. We are very proud of that number. We're losing just about 8% who connect to treatment with the retention. So we're pretty proud of that. That speaks a lot to our community partners and the work that they're doing. With once you're established, most of them are retained in treatment, which is great. Comparably at 30 days, national sample of insured patients was about 16% in treatment at 30 days. And Denver Health was similar to ours at 49%, but you have to keep in mind with Denver Health that they have their own OTP on site, very close to their emergency department. They do an induction and say, come in tomorrow morning between 5 and 9 a.m. We don't have that. We don't have an OTP on site. We have Cedar, and we sometimes send patients there for their addiction med clinic, but we really have those 18 different community partners that we work with. So we're pretty proud of that 45%. In addition to those almost 400 patients, we have given 46 patients a bridging prescription. That might be, like I mentioned before, someone that relapsed. It might be that someone missed their appointment. They're really best suited to go to this community partner, but they can't get them in for another week. We don't see that too often, but someone that we're really just giving a prescription to and making sure that they do have that follow-up appointment.
Great. Just some sort of lessons learned and things that we've iteratively worked on as we've gone. So like everything, when you build it, they don't always come. Angela's been on a couple of news interviews to tell some great stories about success to get it out to the public. We haven't done any actual advertising, but we have reached out to partners in the area, including the local syringe exchanges. Follow-up after discharge, again, can be challenging from the system or the patient perspective. Angela mentioned the privacy concerns, really getting patients to sign the form so that we can send all of that great information that we collect in the emergency department to facilitate their follow-up. And to my knowledge, no one's refused, which is great. The community partners, again, expectation setting. When we first started, it was hard. We would communicate one thing based on our interpretation of other clinics. And when they got there, if it didn't line up with the patient's expectation, that's a point of friction and potentially an opportunity to do better. Continuity of care in the hospital. We've got a great, at UCH, got a great addiction medicine service that could probably use more resources. And really, anytime you start anything else, any new treatment in a hospital, there's a lot of people that potentially can touch that new treatment. And so there's a learning curve for our inpatient colleagues as well. There have been a couple of inductions gone wrong. There are two that I'm aware of that we've reviewed in our case review committee. One was a patient on methadone that was not straightforward with us. That's a problem. If you remember that graph that I showed you, if you're on methadone and you get treated with something that has less activity, that does precipitate withdrawal. And the other one is interesting and something we may see more of, but somebody who was using really massive amounts of fentanyl off the street and knew they were using fentanyl multiple times a day. Fentanyl, we typically think of as a very short-acting medication for pain when we use it in the hospital, 15 to 45 minutes of pain, of analgesia. But when you use it in massive amounts, it has a really large volume of distribution, sort of like how marijuana does. And so it actually goes out into all your fat cells and stays in your system for long periods of time and has a much longer duration of action or longer clearance. And so those patients who are using it a lot, it actually turns into almost like methadone. And so those are the two failures we've had out of the almost 400 patients. Next steps for us, really expansion. As I said, we're building a dashboard that will take into account all of the UC Health emergency departments, and we'll look at what we call a the EPIC phenotype, which is a way of identifying patients proactively without having the providers have to. And so there's the opportunity to see how the care is across the system and look for opportunities to have data-driven responses. And that bleeds into the second one, which is the clinical decision support, where we can, once we've identified these patients, we can actually push it in the provider's pathway and nudge them in that direction rather than waiting for them to pull the patient in. Adolescent inductions, going back, is something we're actively working on. I think we have a call this week. Right now, Children's does not have a facilitated way of getting treatment and initiating care. They have sent patients to us. We just want to make sure that we have the resources to get them the follow-up. And it looks like we have placed a couple, and it looks like we're going to firm up those relationships hopefully this week. Financial sustainability. So there is billing for this work on the social work side. We have not quite gotten to that yet. There is now billing on the provider side. And so quantifying the actual financial offset or trying to quantify the value. Obviously, Angela's team does a million other things besides this. And so there's a lot of benefit for our department to have them on 24/7. In addition to this important work, they do a lot of other work as well. The hub and spoke model, for those of you who don't know that, I mean, that's the idea that there are certain centers where you can refer from the outside for higher levels of care. Is there an opportunity for that in Colorado that we are accepting those patients? Obviously, there would have to be some agreements in place. The X waiver changes are coming. If you don't keep up on this, one of Trump's last acts was to, by executive order, get rid of the X waiver. It turns out that probably wasn't the appropriate way to do that. And so they're working on doing that. There's a lot of pressure on the current administration to get rid of that as well and remove that barrier. And insurance coverage, as I said, is getting better. Our future goals, really trying to figure out, doing research with protected populations requires some extra work, and we're looking at addressing that. We've been trying to work with our community stakeholders to really see what they need and how we can improve retention and treatment and improve access to care for other populations we haven't reached yet. Telehealth, we have a great virtual health center, not quite on campus, but affiliated with the emergency department. Is there the opportunity to reach a lot of those places on the map that I showed you that don't have access to treatment now? A lot of those laws have been amended during the times of COVID and hopefully will be permanent changes. And then last, the group that we've also tried to reach out to, it's been a little bit challenging, is post-incarceration care. So patients coming out of jail or people coming out of jail with an opioid use disorder are extremely high risk of overdose, particularly in the first couple of weeks. As you can imagine, if you go in with one opioid tolerance and are forced to withdraw, your tolerance on the way out is different. And if you go back to using that same dose, that's pretty dangerous. Most of those deaths did involve opioids. It's important because while some of our jails are really aggressive and doing an amazing job, most of that is continuing care or starting care for patients that are in there for long periods of time, versus a majority of the people that go to jail are in and out in 2 to 3 days. And so they'll get screened, they'll identify that issue. They do not have time to initiate care and really get them plugged in. So there's an opportunity for those people coming out that need treatment to really get linked in. And then this little image here was to remind me that there are depot versions of buprenorphine now that last 2 to 4 weeks. And so you can imagine the post-incarceration population would be a great opportunity to protect them before they leave. So they've got 2 to 4 weeks of coverage and are protected from overdose. And so just to wrap it up, our final takeaway. So this is the quadruple aims of healthcare. And so we sort of, to put what we've talked about in context. So how have we improved the clinician experience? We've offered a new solution for, frankly, a challenging population, right? So we had a population of patients with opioid use disorder who were in withdrawal, who were uncomfortable, and made that known. And a lot of the providers were uncomfortable with treating them and really had nothing to offer. And now we can make them feel better in minutes and start them on life-changing treatment, which is great for the providers. We have done our best to not increase the workload on the providers. And there's benefit for the nurses and staffs as well. Having to have patients who are comfortable are much easier to deal with and to engage with than patients who are upset. Lower costs. There's clear healthcare utilization data that there are benefits to starting buprenorphine on patients, including the ED population. There are, as I mentioned, clear benefits to our emergency department with 24/7 social work, and we are trying to expand to other sites and hope to have some benefit for them as well. And lastly, the better outcomes for our patients. So we've heard a lot of great stories about improved access to care, patients who have gone to multiple other emergency departments that did not receive treatment. Angela, I'm sure, can tell some great stories. My favorite one was a patient came in, was successfully transitioned, and a couple of days later brought back his entire family to get started as well. So you can imagine the impact on that entire family unit and their friends. Improve retention and treatment is something we're still working towards, but there are clear public health benefits to our community by doing this. So I showed you that first initial one of how many people die of opioid overdose in Colorado per year, and it's somewhere 700 to 1,000. And so if we're starting 100, 150 people per year, that's, has clear downstream benefits for our community. And then last off, the patient experience has been positive. We've given access to, as the 24/7 provider of care for the community, the emergency department does see a different population than are often seen in clinics. And so we have the opportunity to offer care to patients that are otherwise marginalized or really don't have a lot of touch with the healthcare system. And as Angela mentioned, our low bar for entry has really, I think, benefited a patient population that otherwise would have had no treatment. I think it's important to keep in mind, and I didn't interrupt Angela at the time, but there is evidence that the more times you take buprenorphine and the more times you get exposed, the more likely you are to be successful, like a lot of things in life. And so even if the patients are not successful the first time, we feel confident that this is really an important step for them to be successful in the future. And that's it. I think, unless Angela, you have anything to add, I think we have time for questions.
Yeah, I'm good.
Wow.
Thanks.
Thank you both so much for this really interesting, comprehensive presentation, but also for the work that you do as someone who has benefited directly from this program that you have set up and in being able to offer it to patients. And I will say, as someone who didn't know anything about this and had to be walked through the through the process, I appreciate your attention, sort of ongoing attention to how you make this work in a clinical setting with providers who may not be knowledgeable or sort of comfortable about it. So couple of questions, and to the audience, please keep your questions coming in through the chat box. Sorry, not through the chat box, through the Q&A box. So first question for you both. There's a question around the, and I'm going to add on to it a little bit. So the question was the shift in opioid prescribing, meaning as we've seen providers prescribing less opioids than in the past, or at least more awareness around that because of sort of better knowledge around the risk for opioid use disorders. So the first part of the question is, how have we seen that impact kind of what's going on in the ED? But I'm also curious if you can comment on if we know anything about what the past year has done in terms of rates of abuse perhaps going up in the context of the stresses of the past year.
Sure, I can take that one. So our emergency department opioid utilization and prescribing has gone down consistently at all sites, not with the same rate, but all of the major hospitals that we've looked at within UC Health have gone down. I can tell you when we published this 5 years ago, it was about 20% of discharged patients were on opioid, which seems quite high, but remember, emergency department is a common place for treatment of pain. Now at University of Colorado Hospital, we're down to less than 4%. And so we're sort of at the tipping point where we need to decide, are we bordering on the undertreatment of pain, which has its own downsides as well, and how do we make these decisions more informed? As far as the state, I can show you. So this was recently published. I have our citation here. This is just e-published in Annals of Emergency Medicine. And you can see this is a multi-center study that we were a part of, and looking at the dotted line on the bottom were the predicted rates for this year based on the last 2 years. And you can see at multiple sites geographically across the country, we are seeing increased amounts of visits to the emergency department for opioid use disorder and overdose and excess overdose visits, which again really is the tip of the iceberg if they're actually overdosing, and it probably means there's a lot more patients that are being exposed. And this is Yale, North Carolina, Boston, Alabama, and lifespan, I think, is Rhode Island. So we're seeing a lot of this, and particularly in patients who have a lot of co-occurring mental illness concerns as well.
Thanks. Next question is around, as you mentioned, sort of co-occurring issues, and that we know a lot of patients might be have alcohol use disorders as well as opioid use disorders. So it's going to be a two-part. First, to Jason, there's a question around sort of clinical management in terms of actual treatment. I know our audience, it looks like today we have a lot of clinicians on. Also curious then, Angela, from your perspective, what it looks like in the community in terms of dual diagnosis programs, and how we link those patients to the programs they're most likely to succeed in.
Yeah, so for us, for the most part, we will still initiate patients unless they have a really severe alcohol use disorder. There is definitely a lot of crossover, right? There's also, if you look at the street drugs that we're getting, a lot of our patients are not getting what they think they're getting. So they're also getting a lot of benzos, benzodiazepines, and there's meth in a lot of stuff. So a lot of these are not quite as clear conditions as it looks on paper. And so we still see there's a lot of evidence supporting the treatment of co-occurring disease and co-occurring substance use disorder. And really, you know, it's a piece of a larger puzzle, but getting one under control, particularly one as dynamic as opioid use disorder, where, as I mentioned, sort of throughout the day, every couple hours, you're going up or down, which is what we see with it's particularly injection drug use, and normalizing that physiology really has other benefits to other co-occurring diseases as well. Angela?
Yeah, and I'll say we have awesome community partners. I keep preaching about them. So for mental health, we have had a couple of patients that do really need inpatient psych. We've worked with a couple of our psych units and asked if they can start them on Suboxone when we're there. If it's clinically appropriate, we'll start them here and ask them to continue. Alcohol does get a little bit complicated if withdrawal is in the question. I'm really excited. For those of you who don't know, as of January 1st this year, Medicaid patients now have a substance use disorder benefit to access inpatient medical detox, which is huge. A lot of our patients here that we see at AMC are Medicaid, I think about 50%. So that was a huge barrier we had before, but we can work to get them to medical detox. Opioid use disorder and opioid dependence on its own does not qualify for medical detox, but alcohol or benzos will. So we can work to get them in at Cedar or West Pines, one of our other partners. We do have, like Jason mentioned before, folks that we end up finding out, or they already knew they're HIV or Hep C positive. We have a wonderful provider, Martin Kershak, at our infectious disease clinic here. He also happens to be board certified in addiction medicine. So we've got really good partners where we can send patients to where they're going to be the most successful and get everything treated.
That is fantastic. Thank you. I think we have time for two more quick questions. So the first one to Jason is a clinical question around methadone, which kind of used to be the standard treatment. And can you talk a little bit about sort of methadone versus bup in the treatment of opioid addiction?
Yeah. So historically, methadone has its own issues. Initially, it was for observed treatments where you come in. The classic example is someone going to a construction site, let's say, and they go in and get their treatment every day in the morning before they go in. There's lots of issues with that as far as availability, the control, quite frankly, the ability for our patients to pull that off. Buprenorphine was initially actually marketed to a different population, which was sort of the white collar person with an opioid use disorder, although that's, I think, has gone away a lot. There's still disparities in treatment, but methadone is really now for patients who fail buprenorphine, who need a little stricter confines and observation. And that's sort of who we focus on now. Just remember, methadone does require special treatment programs. It's government run. And so we cannot do that out of the emergency department. We cannot initiate it. We do have policies. If someone's in a methadone program, they miss, or they end up in the ED to miss their appointment, there are pharmacy policies around how we can treat them, make them comfortable, but we don't initiate it because we don't have the capacity. I do think on the inpatient side, addiction medicine does, and they have connection with follow-up clinics, but a vast majority of our patients are given an opportunity on buprenorphine. I would say the other part of that is it really depends how much they're taking. Back to that same graph, if you're taking a massive amount of opioids, you will not initially probably do well on buprenorphine. We're happy to give you a try because the barriers are different, but a lot of those patients do need time to get down to a dose that's consistent with success with buprenorphine.
Thanks. And last, but certainly not least, really important question. So we had a lot of folks from our Colorado community, but what about hospitals either elsewhere in Colorado, or elsewhere in the nation, or places who are interested in starting programs? Where would you suggest that they look? Where would you send them?
From the medical side, there's lots. California Bridge has an amazing. They call it California Bridge Program. They have an amazing amount of resources that are posted online. That's Andrew Herring out of Oakland. He does a great job and has a lot of state support. Colorado has its own. Colorado Health or Hospital Association has the website I listed earlier, and then the Rocky Mountain Poison Drug Center also can call them and they have backup if the physicians have questions in the immediate short term. There are lots of resources. There's lots of barriers that still need to be overcome. And we've sort of compressed it all into a short period of time because we had the money, resources, and providers who are accustomed to changing practice. But you can imagine this sort of over the next 5 to 10 years, hopefully becoming a core tenet of emergency medicine. A lot of that also, we're fortunate here, and Angela mentioned it in passing, but we're fortunate to have a lot of money invested in our clinics so that our patients have follow-up. A lot of emergency medicine physicians are discouraged because they want to do the right thing, but they have no follow-up. And so until those systems are in place, and those systems may look different in different states, primary care may take a lot of the patients who are high functioning and don't have a lot of comorbidities and not really complex. And then other ones may need addiction medicine resources. So it's definitely going to take some time to get these interventions out there and get them implemented, particularly at some of it's unfortunate, but I think in the rural areas are the areas where there's a lot of work being done in Colorado by the School of Nursing and Family Medicine to get that into the rural areas. And so I know they're making great progress, but it will take some time.
Wonderful. Well, thank you for that. Thank you for this wonderful presentation. And most importantly, for all of the work that you both have done day by day and over the years in building this program and really getting these resources out to patients who so need them to really help people get healthy, and it's just wonderful. So thank you to the attendees for coming today. We will send out a link to the presentation if you want to see it again or share it with your friends, etc. If you're interested in continuing the conversation, you can contact me or Lucia Turpak for information about tomorrow's informal discussion group, which is going to be at 4 p.m. Mountain Time on Wednesday. And then please mark your calendar for Tuesday, May 11th. At noon, we'll be talking about school violence and bullying. So thank you again for joining us, and be healthy and be well. Take care. Bye.
Thank you.